Castle,
Here.
Dr. Chapa, Dr. Farmer,
Here.
Sonia Gaines, Dr. Goodkin, Dr. Goodman,
I'm here.
Dr. Harper,
Here.
Dr. Ibrahim,
I'm here.
Dr. Johnson, Dr. Keller,
Luann, Dr. Keller's not going to be able to make it today. He's testifying at the Capitol.
okay. Thanks, Monica. Dr. Lakey,
I'm here.
Dr. Liberzon, Dr. Martin,
Here.
Dr. Martinez, Dr. Mayer, Dr. Mitchell,
Here.
Dr. Nemiroff,
Here.
Dr. Newport, Brittany Nichols,
Here.
Dr. Pliska,
Here.
Dr. Podewelts. I saw him earlier. Okay, Scott Schlacklin, John Scott,
Here.
Dr. Suarez. I see Dr. Suarez. Okay. Dr. Taminga,
Here.
Dr. Thompson, Dr. Vo,
Here.
Dr. Wagner,
Here.
Dr. Wakefield,
Here.
Dr. Wesley,
Here.
Dr. Williams.
Here.
Okay, thank you, everyone. We have 21.
Very good. We're at quorum. We'll go ahead and get started. And again, thank you everyone for your continued work to build out the Texas Child Mental Health Care Consortium and spend a big chunk of your day here today with us as we go over the current progress and hear a little bit about the legislative session and how things are moving forward. I know this is a Monday morning right after spring break for a lot of folks. And so a lot of folks are doing several things, multitasking as we move forward. But again, thank you for taking your time to be part of this. First item of business, we have the minutes from the last meeting. If someone could take a quick look at those minutes, everyone take a quick look at those minutes. And once someone feels comfortable, make a motion to affirm them.
So moved. This is Dr. Ibrahim.
Very good. I have a motion and a second. Any further discussion? Hearing none, all in favor signify by saying aye.
Aye. Aye.
Opposed, nay. Hearing none, they are confirmed. Let's go to the third item for information discussion about the implementation of our initiatives. And we'll start off with the fiscal agent report from the University of Texas at Austin.
They may not be here. Oh, there's
Yeah.
Linda.
Yep.
Hi, Linda.
Hi there. Good morning.
Good morning.
Let's see. I'm going to share my screen so you guys can see. I sent it to the group, but I just want to get on the screen as well. I knew I was early, but I didn't know it was this quick. Apologize not being ready. I was multitasking. I was reading emails. There we go. All right. Apologize for the delay. All right, just a quick update. Wanted to let you know that contracting wise, we're doing really well. We're not having many amendment requests that have come in and everything, and all the contracts had been fully executed. The same with invoicing. After last month's update, we have received the majority of invoicing from almost every HRI except for one, which we're in communication with. So they're coming in quite currently, and the payments are going out promptly as well. I have a report to give you of what we have through the month close of February, and then I want to give you a reminder that our next federal recording reporting deadline will be at the end of March, and that'll be due in April. So the update that we have for the different initiatives that have come through and that we've paid for on sub bills that we've received based on each of the initiatives is there for everybody to view. So as you can tell, we're making some progress in some areas, and then others that have a smaller feedback, they have been communicating with the program officers and stuff that their focus has been putting on initiatives that were ready to go and could go pretty quickly. So we're not surprised when we see lower expenditures in some of those areas. Are there any questions from the group or comments?
Linda, I don't think your PowerPoint was shared.
Oh, I apologize. I saw it with the border on the screen. So let's see. Let me try it again, hit the button twice.
There you go.
Apologize. So you guys seen the PowerPoint now?
Yes, we do.
Okay, perfect. Apologize for that. So the first slide that you missed was just the agenda item for me talking about the contracts, invoicing, and reporting, but it's in the packet for everyone as well. And then the graph is the most important document to show what we paid to date on each of the program initiatives so far that the HRIs have turned into us, including Meadows.
Okay. Are there any questions? All right. Hearing none. Thank you, Linda.
You're welcome.
Before I go on with the rest of the meeting, I've just been notified that, and I just want to let people know this is occurring, and you know, part of the reason why we are doing this work. But at Arlington Lamar High School, we had a shooting today. We had a suspect that's in custody and 2 students that are injured. Again, just want to make sure people are aware of that. You may see information about that on your emails, etc. But want to make sure people are aware of that. And again, part of the reason that we're doing this work, and there'll be more to find out. But again, just want to make sure people are aware of that's happening, breaking right as we're having this meeting.
Dr. Lakey?
Yes, sir.
I was just informed that one of the 16-year-olds that was shot has passed away.
All right. So again, I'm going to suspend format here for a second. And if we could just take 30 seconds for the families of the people that have been impacted by another school shooting here in the state of Texas, I'd appreciate it. Okay. Well, sorry that we have to start our meeting off with that. And Alan, if you learn more, it sounds like it's up in your area. If you learn more, if you could let us know, would appreciate it. Thank you.
Thank you.
All right. Next item is the overall administration. Luann, you and Lachelle, you want to jump into that update?
Yeah, I think between myself and Jonathan, we have a couple of things. First one we wanted to mention was around communications. I know there's been a lot of back and forth recently about providing us presentations, other materials that you're developing that maybe have the consortium branding or relate back to our programs. Just wanted to emphasize that it is important that we have oversight of these materials, and there is a process associated with that. That said, also wanted to just say one of our team members, Laura Cruzada Davis, who your team members have probably been working with, is going to be moving on to another opportunity. And we wanted to take this time to thank her for all the work that she's done with her time here with us, and we're going to miss her a lot. So we will continue to review those materials. There may be some changes in terms of timing of those, and we'll communicate out to you about that soon. We're hiring some students to help us with some of the review from a branding perspective. And we're also going to be posting for a new full-time communications person within our department, and hopefully that'll be posted soon. We're also looking to bring on another program manager, so be on the lookout for that person. We're going to try to delineate some of the work that we're overseeing, given the huge amount of information that we're receiving on TChat, and then the expansion of CPAN, PeriPAN. Our team is trying to diversify so we can really focus on data that we're receiving and having those relations with all of the team members on your side.
So a quick, if I could just jump in here, a quick thank you to Laura. She has been doing great work for us here. She got one of those offers she could not refuse from some folks that knew her well. And again, we're just grateful that she was able to spend the last year plus time with us here to improve our communications and to move things forward. And so Laura, I just want to let you know a heartfelt thank you for the great work that you've been doing.
Thank you, Dr. Lakey, and thank you, everybody. It's been such a pleasure and honor working with you and being able to support all the great work of the institutions.
All right. So obviously we'll have a big hole on our team that we're going to need to fill, and we'll be working to fill that position and continue to strengthen the communications aspect of our work. Michelle, anything else?
Yeah, and just a quick update on some financial reporting that will be coming out soon is we need to report back to the statewide behavioral health on all of the spending for the consortium. And so that includes reporting on FY21. So all of the encumbered funds that were spent in 22 for 21 we'll need to get, but you'll be getting an email from us about that. Just a heads up. Thanks.
All right, thanks, Jonathan. Next on the agenda, the update on the PeriPAN Psychiatric Access Network. Dr. Wakefield?
Yes, I have a slide set with the COSH slide, so I'm happy to talk about that later in the agenda, if that's okay.
Yep, I'm happy to do that. That's great, thanks. And then on the collaborative care, Meadows. Tanya, I think I saw you just a little bit ago.
Here, hi, David. Good morning,
Hello.
everybody. Thank you for the opportunity. I think we have a few slides to share as well this morning.
All right, very good. Thanks, Honey.
Of course. Thanks, Michelle. We can go to the next slide, please, and thank you. So our updates, we usually break these up into a few buckets relative to what we've accomplished, what's coming up, and then ahead of the curve there. In February and March, we really focused on one-on-one meetings with our different HRIs and any associated internal folks on their health systems that they've recruited. So the beginning of February and most of March is being spent on those one-on-one targeted meetings to really focus on what these HRIs need in the way of technical assistance and what kind of supports may be idiosyncratic to their region, et cetera. We've submitted those monthly reports for February and March, of course. And I'll speak a little bit more to that inaugural Pediatric Collaborative Care Roundtable that occurred at the end of January. But we're in the process of reviewing those results and putting together the findings in a meaningful fashion. Next month in April, we are going to be completing our monthly reporting as usual. We're going to be shifting back from breakout groups into a more of a learning collaborative in which we bring all the HRIs back together again and share resources relative to not just the roundtable and a collaborative care billing curriculum, but also focused on kind of what the different HRIs and health systems have identified as facilitators or barriers insofar as their specific sites and what they have done to overcome those over time. And then forthcoming, we'll be looking at continued recruitment of health systems with assistance of HRIs. Our TA opportunities will continue forward, and then our typical metric reporting month to month. Next slide, please. Metric data as of March 15th, we're kind of in that same place where we're with 7 health systems and that same number of individuals initially reached a little over 42,000 through those 7 health systems. We're getting closer to a few more health systems coming on right now. And we are on course for what we would expect to see at this time a few months into the initiative. Next slide, please. So a little bit about the Pediatric and Adolescent Collaborative Care Roundtable that we held. We spoke to this in our last consortium meeting, but we brought together 20 pediatric collaborative care leaders through a 2-day roundtable discussion at UT Austin Bell Medical School in concert with the Department of Psychiatry and Behavioral Sciences. Attendees were CAPS, pediatricians, care managers, researchers from different health settings in different regions of the country. And we led discussions that were pretty targeted and focused really on the clinical side of things, looking at those facilitators and barriers to not just implementation, but what a path forward for uptake of high fidelity pediatric collaborative care would look like, what folks have found in the way of solutions and their takeaways across those dimensions. We're looking at major themes, solutions, any gaps that came up in the way of consensus versus disagreement from those attendees and those breakout groups that we had during the roundtable. And we're trying to finalize those proceedings. And the applications noted here for discussion on the horizon. Of course, we're going to be circling back with the attendees and providing that information to them. But more importantly, we're going to be taking the key findings and disseminating that across specifically this project with our stakeholders in the ARPA Pediatric Collaborative Care Initiative, making sure HRIs and their associated health systems are aware of those findings. And then we're also going to be putting together a small bit of a presentation here for the consortium when the time comes. Most likely that's going to be in May. So we can get that information to you all as well and field any questions that may come up as a function of that. We have brought up this notion of considering subsequent roundtables, mostly because people keep asking, and they were very enthused by kind of that initial go and looking at bringing in potentially some different folks in the way of more pediatricians, different folks that are doing adjunctive types of work in those settings as well, to see what we can do about, again, addressing the implementation barriers that have been ubiquitous over time, but seeing what we can do about addressing them meaningfully moving forward with not just state, but federal funding. Next slide, please. Also note that at the beginning of this month, our Meadows TA team worked with folks out in the El Paso region in West Texas. We met with physicians, APPs, and other primary care providers and administrators in the El Paso community. We had a nice showing there of folks who were pretty engaged and spoke specifically about the challenges related to behavioral health access in West Texas and in that region. We had some folks from New Mexico come in as well to garner some information relative to different behavioral health integration models and looking at different efforts that are being pushed forward right now and hopefully in the future as well, specifically focused on how collaborative care can address some of the workforce shortage, as well as issues with respect to the clinical side of the pediatric mental health crisis. Next slide, please. That's it. I'm happy to field any questions folks may have.
All right, very good. Any questions for Dr. Levy? All right. Any comments, any issues in rolling out the initiative in your area that we need to share? All right. I'm not hearing any. So thanks, Hani, and thanks for shepherding this good work.
Appreciate it. Thank you.
All right. Dr. Blader, let's transition to you on the update on the substance use disorder initiative pilot that you've been putting together.
Great. Good morning, everybody. All of our 4 sites, which are us here at San Antonio, Dell Medical in Austin, UT Health Science Center at Houston, and Texas Tech at Lubbock, we're all in various stages of seeing patients and delivering care. We're trying to reconcile some issues about the numbers of individuals seen and number of sessions through via the trade platform versus our other sources of information. So The most current information that we have from the trait data capture platform is that we've through January 31st, we've had 48 individuals seen with 105 contacts. I can assure you that in the last 6 weeks, there's been a very significant increase in the number of referrals seen, our overall clinical activity. Hopefully we'll be reporting on those trends by next month. And the other development is we're finally getting underway with the Partnership to End Addiction that provides specialty training and evidence-based family treatment approaches for adolescent substance abuse. And we anticipate having our launch with that partnership and consultation in the next few weeks.
All right. Any questions for Joe? So Joe, I'm not seeing any, but again, it's good to see things picking up. And again, I've been privileged to listen in the meetings, and last meeting, a lot of energy related to the consults that are coming in and the standardizations of methodologies and everything else. And so it's coming to be. And so thanks for your leadership and putting it all together and seeing this. And again, look forward as we continue to build that, thinking through kind of what's next and developing that into a more available initiative throughout the state.
Okay. And thank you for your support, David.
No, absolutely. All right. So Dr. Trivedi, let's go to you next for the update on the Youth Aware of Mental Health initiative.
Wonderful. Thank you. Can you see my slides?
We can. Yeah, there we go.
Perfect. Thank you for the opportunity. So we, just a little background on this so that people are aware, we have outreach tools that are developed and updated as needed for each school district. We have instructional tools for implementation teams developed, and we have now videos available for leadership as well as school personnel to review for their understanding of what the program is. And there is a whole elaborate process of engaging with schools. So what happens is that there is a contact with a local HRI for YAM, and these are the institutions that are participating, and then information sessions are offered for all stakeholders to make sure that everybody in the system is actually on board. So what ends up happening is any principal, counselor, teacher, or school staff, parent, or community contacts the local HRI to start the process of bringing YAM to the school. Once this contact is made, the HRI offers information session for all stakeholders, including and not just exclusively. So these are at least the major stakeholders that get information: superintendent, school board members, principals, school staff, parents, community members. There are student meetings. We talk to the hub as well as the HRI is available to provide all these information programs to all the stakeholders. And then once that happens, then there is an official memorandum of understanding signed between the ISD and the local HRI. Then that creates the opportunity for us to schedule in any given school at any given grade level that has been agreed to. Obviously, the target population that the program is organized for, there is evidence for, is 8th through 12th graders. So that's what we don't go below 8th, and 8th to 12th is what ends up happening. As I mentioned, there are resources available for parents, for parent opt-out forms, and the hub as well as the HRI is available. We've done many sessions, and I can give you more details about that if anybody's interested. I just wanted to give you some idea of where the progress has been so far. So these are all the trainees across all the HRIs. So the good news is all HRIs have been trained now. And there are several facilitators at every HRI already trained. These are the school districts that have officially signed MOUs. So you can see the level of interest, I have to say. All of the leadership of the TCMHCC, David and all, we are actually now at a point where we are getting requests for more schools than we are officially immediately accommodating. Obviously, there are scheduling issues and all that. So this is actually wonderful and something to actually really behold, because having to go through all of these processes and have a signed MOU between the HRI and the school district takes a lot of time and effort and availability. And so it's been wonderful to see. This is the bottom line. So we have already, and remember all of the scheduling, the contracting issues and the scheduling issues and all that, but we have reached over 8,500 students so far. Our promised reach for this time, this school year is 10,000. I have no doubt we'll get to that. And you can see the rise in the numbers. The spring numbers are slightly smaller than the fall numbers for two reasons. One is we still have some schools that we are doing for the rest of the school year, and fall as it is generally a very rich time for schools to start thinking about new things, and that is why we'll see more numbers again next year. These are the school classes. Each school obviously has different class sizes, and so the total number of classes we have reached is 442. Our goal is 650. These are in this spring itself. So this is up so far, 2,712 I showed you earlier. We have reached 137 classes. I want to again, it sometimes gets lost and I will keep on repeating, so pardon me for that, but bears repetition. This is the entire classroom. We are at the TCMHCC level. Nobody is able to articulate the excitement more than David does, so you do, but we are offering a whole lot of programs, but almost all of them are assigned for kids once there is a problem identified. This is different. This is earlier, before problems are identified. So the classrooms we've reached are quite a bit, and that really covers the entire classroom. One more thing is all the HRIs that are involved are actively doing this. So that's the other goal we had originally, that it just not be just at 2 or 3 or larger centers, but everywhere. You can see number of students and number of classes addressed. This is the distribution of what we are going for. Obviously, the 9th graders often end up being the most likely to be able to, we can schedule, and so you're seeing larger proportion of 9th graders. Gender distribution reflects the school's population. Ethnicity-wise, we are reaching 40% Hispanic population, and the race distribution you can see is very much reflective of what we see in the state. So we are not, or positive speaking, we are reaching the population at distributions that we wanted and have been getting there. The main issues for us, takeaway messages, is 28% of these students screen positive for depression, 32% for anxiety. And what's been seen nationally, and unfortunately we started the call today with this question, 8.8% of these students do reflect significant thoughts of death, suicide. So this is a big problem that we have to be, as a group, thinking about. Remember, this is not where people are already in treatment. So this really is beginning to give us a sense of how we can reduce this larger burden of the illness later on if we can do something at this stage. So this is actually in some ways a call to action, if not. You can see that people the students who screen positive versus those who do not have a significant difference in several important parameters where, again, we can go and intervene. Their risk for suicide is higher. Their problems in family relationships and peer relationships are much higher. So that is another place where we can make an impact and reduce the burden, so that if we can do something for the third and the fourth family and peer relationships, build some resilience, put in some suicide education programs, we can reduce this number. That is the hope, and that is something we got to think about as we move forward. If you have not paid attention to any of my slides before, this one, I think, would bears your attention. So this is thanks to the legislature, and David, you raised it several months back for us to think about what is happening with social media use in this population. I think this should give us pause, guys, folks. We have been all agreed as a society that tobacco use is horrible. And the bad news is it is really bad. Tobacco use, fortunately, the impact is 30, 40 years down the road. This social media use you can see here, and I'll walk you through each aspect. Kids who have screen positive and look at the Saturday, Sunday usage, there are differences in the number of kids who use more than 5 hours compared for those who screen positive versus those who screen negative. Same thing with, I feel disconnected from friends when I have not logged onto any social media. Social media plays an important role in my social relationships. All of these factors are more negative in students who screen positive for depression. We don't know the relationship. This is too early, but I think that we really have to pay much more attention to this. The ravages of what our teenagers, especially we are beginning to look at this, but the impact of social media use in young girls, teenage girls, is really likely to have a bigger impact. That is where depression, anxiety initiates. This is the population when the first onset of illness happens. So I think this is something that we'll follow more about. I'll keep updating you all on the progress we are making with this information, but we may want to put some more thoughtful further assessments in this domain. Their mental health literacy, thankfully, is improving. Like, I believe I know where to get help if I ever experience mental health problems. Completely agree and somewhat agree. Are increasing at the end of our 5 sessions. This is just 5 general sessions. These are literacy sessions. These are for the entire classroom. Some kids pay attention, some don't. All of that, as you all know, what happens in classrooms. And yet we are seeing that improvement. We are seeing improvements in the question of, I know that there are several ways to treat mental health problems. So the final good news is we did get a peer-reviewed grant from SAMHSA to develop youth advocates for mental health. It is a SAMHSA grant for the training academy we have at UT Southwestern. The goal is to develop youth advocates for mental health through the system, and we'll work with each of the HRIs to see who is really interested, and then we'll go from there. I'm going to stop here in the interest of time, but happy to answer any questions.
Very good. Thank you, Dr. Trivedi. Any questions for Madhukar?
Nice work, Madhukar.
Thank you.
Very good.
All
right, let's transition then to an update on several other initiatives, starting with TChat. And Lachelle, I have your name down here for that update.
Is Safety A going to be?
Oh, I skipped over Safety A. I'm sorry, Dr. Williams. I didn't mean to neglect the importance of Safety A. Let's hear from you about how things are going.
I stuck it in the COSH report, so we can move ahead if you don't mind.
All right, Lachelle, we're back to you.
All right. Let me share my screen really quick. Just going to show everybody the report that we generate on a monthly basis. It goes to the governor's office and also to the TEA. This is through the end of January. We're currently consolidating February's information. Dr. Molly Lopez is, and as soon as she gets me those updated figures, we'll have a revised version of this out, hopefully by the end of the month. As you can see, we're making really great progress. HRIs are making great progress and continuing to roll out TChat across the state. We're almost at 50% active, and certainly with the number that we've got onboarding and pending, it looks like we've only got a little less than a third left to start reaching out to and initiating those conversations around the MOUs. I will say that we met with Julie Wayman a few weeks ago to talk about how can we better collaborate with the TEA and their relationships with the ESCs to ensure that everybody's aware of where we're at in the rollout of TChat. And how do we better communicate and create those lines of communication so that everybody's aware of where we're going next and they can help us with this rollout. We have a meeting on the 22nd, and Luann may want to talk a little bit more about that. I was out last week, but we're working to create reports that will go to the TEA and specifically to the ESC leads so that they know all of the districts that currently have TChat in their regions, and which ones have declined and which ones are left to be engaged. And we're hoping to leverage those relationships. We're going to have an introduction between the HRIs, TChat leads, and the ESC leads, and make sure that everybody is aware of their points of contact and can answer questions, and hopefully continue to roll out TChat with the goal of getting into every school that wants it across the state. There's a couple of pages here. I'm not going to go through all of them, but this last one, reasons provided by districts for declining TChat services. It appears that the majority that are declining because they feel that they already have mental health providers or an existing telehealth or app that's supporting them. There's a few that have declined because of lack of space or resources, or have said they will consider at a later time, and very few that have outright declined because the board or the administrator declined. We have had a couple that have come back to us after declining, saying that they would like to now have TChat in their schools, which is great. It shows that the schools are talking to each other, and our reputation is thus that people are trying to reach out to us now and get TChat in their schools. So I just want to compliment all the HRIs for the hard work. I know it's very difficult to get this rolled out as quickly as we're hoping to do so. So just wanted to thank you all.
And let me add my thanks to everyone. First for, again, working hard to roll out TChat to all the schools that want it in your area, and for providing the information. I know Lachelle and our team are contacting you on a regular basis to make sure we have as much up-to-date information as possible. This report has been very useful. It is being sent now to legislative leadership on the Senate side, on the House side, and in addition to the governor's office and TEA. Actually, one of the pie charts that is in that report ended up in the governor's budget request. And so again, just kind of shows that people are watching this information and are very supportive of the work that you're doing. Are there any questions related to that report that we're putting together? Okay. I don't see any hands, but again, would continue to encourage you to keep working with the schools and the ISDs and making sure they are aware of your presence and the program and the desire to partner with them as we continue to make this available. With that, let's go next to the internal evaluation. And David, Molly tells me that you're providing the report today.
Correct.
Very good.
Good morning, everyone. Happy to be here with you. David Lynch from the internal evaluation team, providing a quick update of efforts with me and my colleague, Dr. Molly Lopez. Don't have any slides, just going to read off a few bullet points about some of the things we're working on currently. The first is just to continue working with the school districts to provide that foundational information that Michelle just provided, that just showed on the rollout of TChat. Also administered a provisional Peri-Pan experience survey, so enrolled clinicians could provide their feedback about the program's usefulness, comfort managing care, and ways to improve services. We're currently interviewing candidates for our new data analyst and program manager positions. and provided some summary utilization information, survey results to UT Center for Health Communications to help promote CPAN's upcoming anniversary. And if anybody has any questions or would like some of the summary data we provided on any of those fronts, happy to provide that. That's pretty much it right now for us.
All right. Any questions? Okay. Well, then let's go next to the external evaluation and our team from UT School of Public Health. Dr. Lamas?
Sure. So I'll be giving a verbal update also. And so our evaluation work has focused on beginning this year, again, reviewing the existing data and preparation activities for analysis based on data coming from TRAIT, and then focused on preparing for our surveys of the CPAN and TCHAT programs, as well as the qualitative work with the CPW program. So in terms of the TCHAT survey, we've finalized the TCHAT survey items and are planning to send our annual TCHAT survey to school district staff who coordinate or are involved with the TCHAT survey. The purpose of this survey is to describe the characteristics of schools that are using TCHAT and to try to identify barriers and facilitators using the program. And we look at this among those that are fully using it, and looking at facilitators and barriers to both use and less frequent use. COSH and the internal evaluation team have reviewed the survey and have provided feedback, and we're finalizing survey also based on our year 2 results. We plan to survey 300 school district staff this fiscal year with an active MOU, and the plan is 100 from schools that join TCHAT each of the 3 years. We have also finalized our sampling frame, and we'll send that out to reach out to identify the school contacts at the sampled schools. So our goal is to begin administration of the surveys in April. And we do use the similar process to update our CPAN survey, which will be sent out to providers in the summer. And we're continuing to work with COSH and internal evaluation team on the data cleaning protocols, as well as provide input on the TRAIT programmers for quality improvement protocols based on our cleaning processes and tracking of TRAIT data. And then we are also using these processes to refine our monthly cleaning procedures, and we'll be starting to download TRAIT data and clean it to provide monthly updates to our data boards for both the TCHAT and CPAN programs. And we'll start presenting those again now that we have the data in place. And we do these dashboards by population characteristics, so we can show kind of this spatial visualization of the schools recruited into the program by different population level characteristics, like the child vulnerability measures that we've identified, and the same with the providers recruited in clinics. And so that's where we are right now. I don't know if anyone has any questions or feedback.
Very good. Thank you, Dr. Savas. Any questions for Laura or Dr. Peskin? All right. I'm not seeing any. Again, thank you all for your continued work and helping us make sure we're moving in the right direction. So thank you.
Thanks.
Let's go next to the communications update. And Dr. Sussman, I think that update is from you today.
Hi.
Melanie.
How you doing? I hope everyone can hear me okay. I'm gonna share my screen. Okay, can everyone see the presentation? Yes, okay, great. I can see a couple of you. So, okay, well, thank you for the time to kind of update you all on what we've been working on over here at CHC. Okay. So these are some things that we have accomplished over the last quarter or so, working with CPAN and also beginning our work with PeriPan. We conducted PeriPan listening sessions and with each of the pilot HRIs, and heard some of the ways that they're doing outreach, and created a list of different items that they may like to have, so we can start thinking about those things if and when we go statewide. We also did a hold on, I can see my face 2 times and it's distracting. Okay. We have participated in the community of practices that Laura created, and that's when we get all of the HRIs together, the coordinators and the marketing team, outreach teams, and go over some different learnings together. So we've done 2 of them. We did it on newsletters, and we also did it on social media. I think our next one will be about specific outreach, and those I think have been really helpful. We also did an in-person outreach trip to Baylor to work collaboratively with that team to see if there was any kind of fine-tuning that we could all develop together around outreach. And we're putting a report around that together. But we did visit, we had a very busy 3 days. We visited over 50 clinics, enrolled 4 clinics that over that period of time. We had a conversation about the usefulness of this practice and this kind of fine tuning. And the coordinators felt that it was useful. We got a 4.5 out of 5 on usefulness and helpfulness. So we'll be monitoring those clinics that we went to over the next 6 weeks to see the impact of that trip. We also created some newsletter guidance that we shared that Laura's team is working on, and shared stakeholder reports for CPAN that listed statewide potential partnerships or collaborations, and then also regional ones for those groups to work on. We're doing it a little bit differently with PeriPan, and that we're trying to do a deep dive with 7 key organizations through them. We've done ACOG and we've done the Family Practice Association, and we'll be moving on to a few other. And then we're still continuing to support creative development. This slide, the second little visual that I have here is the CHC also has a project around prescription drugs, the prescription monitoring program. So we try to, when we are doing something that's relevant for all the stakeholders, cross promote or do outreach that way. So this is the series of grand rounds for PeriPan that we sent to prescribers around the state, so they would just know that those were happening and hopefully register. The next slide is around our social media efforts. So we've seen a very lovely increase in LinkedIn participation and growth. So we've had a 72.6% increase. We have 183 followers, which is good. It's really good to be growing that professional audience. One of the things just through these slides that with these visuals that we try to continue to emphasize is quotes from providers that are using CPAN, because we know that providers adopt behaviors when other providers do as well and talk about it. And then we do a program profile. This one's on texting. And then we also share some stats. So those are 3 of our social media graphs. This is a busy slide. I had a lot of things I wanted to show you. This is about our digital outreach analysis. So we've been doing this since August. We have had over 6 million impressions of these outreach. They're down here. These 3 are the outreach. We continue to see the highest performing has to do over here with the emotion of feeling more confident about providing mental health. Videos also perform very well. And then the resources and the vetted referrals also do very well. So over 18,000 clicks after seeing this. You can read the statistics here, but I want to show this. Here is the website year to year. So you see the campaign started in August, and we kind of get a bump. There are lots of factors. There's so many people working to increase utilization for CPAN. And I think that this campaign also shows the impact. You can see the impact of this campaign by the jump that we see in the website. And then here you see the website use year over year, and there's a nice divide once the campaign has started. I put it next to some of the CPAN consults from Trait, just so you can also see the jump from July and August. And then just this kind of steady increase, which is, as I'm saying, due to many, many factors, one of which I believe is the digital awareness building campaign. Finally, what's next? We're focusing on CPAN's 3rd anniversary and promoting the theme of threes. And we will be getting some creative to our team soon. Top 3 reasons clinicians call CPAN, 3 reasons CPAN fits in your day, 3 statistics. We'll be creating content for an e-blast from the HRIs to send out, and social media as well. One of the 3s that I neglected to put in here is also share with 3 of your colleagues something about CPAN. So we're also working on the website pages for CPAN and PeriPAN. This graphic to the right is a little hint of some of the things that we're working on for that. And then for PeriPAN, we continue to try to build some foundational and outreach items. We're working on the provider toolkit. We are working on the video. The script is in its final stages. The stakeholder partnerships, and then we're also looking at a direct mail piece for the pilot areas. Questions?
Very good. Thanks, Melanie. Any questions for Melanie? Well, I don't see any, but again, thank you for all the work to continue to build this out. So thanks. Let's before we go to the next item, a quick little roll call check. I saw several people that have joined us since we did the official. And so Dr. Suarez, I saw that you have joined us. Anybody else? Any other members of the executive committee that have joined us since we did the official roll call?
Did you get me while I went out for the fire alarm?
We did. Yeah.
Thank you.
Yeah,
And
I'm
Israel.
here, David.
Okay. All right.
Dr. Johnson.
And Dr. Johnson. Okay. Anybody else? All right. Very good. So, Dr. Williams, Laurel, let's go to you with the COSH update.
Okay. Hello, everybody. Hopefully your day is going okay, and I'm gonna let Edith get us going with the slides. And we will probably only take about 10 minutes. It's a pretty brief update as well. Edith. Hey, we don't see her. There she is. Perfect. So hopefully, for those of you who follow basketball, I was about to say football. Clearly, I don't follow it. It's been a surprising. Sounds like a March Madness, but we're going to just do our COSH update, and we'll go ahead and go to the next slide. So we're going to talk about updates specifically around Safety A, then CPAN, and then I will hand it over to Dr. Wakefield for PeriPAN, and then we'll talk TChat, and then we'll be done. So we'll go ahead. So we did want to talk about alignments. Again, with Lachelle sort of talked at the top of the meeting. COSH is working with feedback from evaluation teams, from Luann's team, from HRIs. And so we're doing a little bit of restructuring to be kind of better in alignment. So the The data analysis piece is now going to move over into the internal evaluation team. My understanding is that they are interviewing right now. So that's a restructure for us. We have a new team member. One of the things that we got feedback on is just sort of making sure that we kind of keep everybody apprised of all the different moving parts to Lachelle's comment earlier. And that really made us think from an operational perspective that it's really the two teams are too big to have just one person sort of being a program administrator. So we did work with Luann and her team and with Baylor to develop a new role that both Edith is going to be in, as well as a new team member is going to be joining us in April. So Edith is going to, starting in April, only oversee and manage operations related to CPAN. And then our new team member, Jennifer Cole, who's coming in April, she will then oversee and do operations related to TChat. So those are the sort of pieces from a new team members and sort of a restructuring of the data sort of piece. So we're very excited to have Jennifer Cole come on to work with us. And Edith is going to just sort of lead the charge related to CPAN. Next slide. So it's related to Safety A. This is formerly was called FISP. Dr. Pinsonati has been overseeing this program. I asked if she wanted to present and she said I could happily do it for her. So that's what I'm going to do my level best. So next slide. So just as a reminder to our point around what is Safety A. Safety A is an evidence-based cognitive behavioral youth and family-centered intervention related to suicide and self-harm. It originally was put in to assist emergency room teams and physicians when somebody came in to an emergency room with either suicidal, self-injurious thoughts, behaviors, or actions. This has now been adapted to also be able to be utilized within a primary care clinic and visit. And the goals of Safety A are, of course, to reduce risk around suicide, self-injurious behaviors, ensure safety, and assist with linkage to care in the community. This is not trying to make a primary care physician or his or her team become a mental health provider in the way of like having to do therapy or, you know, making decisions right then about care. It's really about how to safely co-construct with a family, a legal guardian, and the young person a safety plan as they kind of move into the next sort of care process. And so we kind of liken it to physicians and know what to do with a code blue. They know the steps to take. Safety A is, again, kind of that scaffolding, what the steps to take if you have somebody come into your office with this type of healthcare emergency. Next slide. So again, a Safety A use session, again, it can include both the primary care physician, their nurses, it can include their case manager. It really is, it should be a team approach along with the parent, legal guardian, and the young person. It's the assessment of the suicidality, identifying strengths within the young person and their family and their environment, understand potentially what emotional reactions are associated with the current concern related to suicide, and then develop a plan that's specific to that young person and family so that they can sort of navigate the next several steps or time in the young person's life. So again, ABCDs: assess, build hope, create connections, and develop a safety plan. And so really helping primary care providers have a scaffolding, a sense of how to do this. Next slide. So again, it's a session, and it does not always have to be only the pediatrician, the family physician who's doing this work, but it is sort of talking about educating the family, talking about the behaviors, coming up with ways to reduce lethal means restriction, including things related to substance misuse, protective monitoring for the family, and supporting the young person, and obviously reviewing that protocol. Next slide. So what we're doing with the ARPA implementation is specifically looking at the feasibility and acceptability of doing Safety A training and implementation within primary care clinics. We had a very modest goal of training potentially 50 primary care physicians across the state by November. And there are 7 teams that are providing Safety A and with primary care physicians. Baylor is sort of leading with the sort of piece related to organization, operations. Southwestern is helping with the with getting us contact with the Safety A people and also with the data management. And then the rest of the teams are involved in recruitment. Baylor is also recruiting as well. Next slide. So we did have our first cohort. We have 3 cohorts that are already planned. And so the first one happened about 2 weeks ago now. One of the first things we need to do with the cohort is actually train the trainers, because one of the ideas that we have with ARPA and the Safety A progress is actually to have the people become local experts in their region in Safety A, so they can go out after this initial pilot and continue to train. So the first cohort was really more about training our own team to become eventual experts in Safety A that they can turn around and train people. So we had 46 in attendance with 12 staff undergoing the training. We have additional cohorts that are happening the end of March and also in April. Next slide. All right. Any questions about Safety A before I move to CPAN specifically? All right. CPAN. Next slide. So for direct consultations, we have 7 of the 9 teams that have been providing direct consultations. 2 teams have just started to stand up. They have not yet done an initial consultation, but they were able to utilize the information that they got from the other teams that were sort of the beginning people to pilot it to sort of help them get going with their own consultations. So we expect for those 2 teams probably in the next month to also have direct consultations that they are also providing. To date, since we started in the fall, we've had 142, and in progress currently is 24 direct consultations. Next slide. We just wanted to put this up because, again, when we look at the dashboard, you only see the previous 6 months. So it's helpful, I think, from a visualization perspective, just to see kind of where we have been and where we're going. To Melanie's point about we're talking about the 30-year anniversary. Again, we've had year here, I think, pretty significant growth in our CPAN consultation volume. As to Melanie's point, a lot of moving parts have come all together in a very nice symphony, right? I would say it's a symphony. There's lots of different members, and they all are absolutely essential to make this progress that we've made. So we're starting off this new academic calendar year with a large increase in the number of consultations provided. So this is lovely to see. Sorry. Next slide. Just gonna briefly manage over to the portal, and then we'll move on to PeriPan after that. All right, it's always weird to do this in Zoom. Prefer in person. So she's going to hover over the provider list right there. So it's again reminding ourselves that this total number includes both physicians, pediatricians, family physicians, nurse practitioners, PAs. So this is a total number of people, and we have close to almost 2,000 clinics if you round up. We're continuing to do very well with returning our call back within 30 minutes. Now we do have the opportunity for physicians, or if the provider doesn't want to call back in 30 minutes, but when they do, our metric of 9% and above, we're continuing to do very well with that. As you can see with the clinic type in the middle of your screen with the donut, we have again a healthy mixture of the types of providers, pediatric, family medicine, as well. And if you move down then to the middle part, Edith, you can see our consult volume. The middle part, thank you. As you can see here, again, we've had our now highest month ever in the month of February, even with an ice storm, with over 1,000 consultations. As you can see to the donut on the very right, again, the majority of people who call us are physicians. We are working with a trait now that PeriPan has become a pilot. We're going back and actually putting behind physician name what type of physician they are, because it now becomes important now that we have obstetricians and other physician types. But we have still a significant amount of nurse practitioners who utilize the phone line, in which we're very thankful for that. So we have a continued wide variety of providers calling in. And again, we're over 50% of people calling once they've called once. So we do think that people are getting value out of this. And once they've called one time, they're likely to call again. All right, so now we'll stop sharing this and we'll move on, I think, to PeriPan.
Laurel, the Peri-Pan slides are in your slide set, right?
Yeah, I think Edith is just pulling it back up.
Thanks.
Just switching between the two. Hopefully. I saw them, so I know they're there. It always takes longer than you think it's going to take. There you go.
All right. Well, exciting news. We are 40% overall pilot-wide enrollment. Some of our regions are actually closer to 50% enrolled in their pilot regions. We're really excited to have hit this target. This is reflective of the number of, or the percentage of obstetricians who are enrolled in Peri-Pan specifically, who were not previously enrolled in the CPAN. So this is new engagement. Of course, we also offer our services to all family medicine physicians, advanced practice providers, and pediatricians who pediatricians have the highest recommendations for screening of moms actually in that postpartum period over those well child visits. So we do offer those, but because we had already engaged so many of them in CPAN, we didn't utilize it as a metric for Peri-Pan. So this is reflective just of the brand new engagement of obstetricians in these pilot regions. So thank you to our teams. This has taken a lot of effort and we're very excited about this. Next slide. The purpose of the contact. So most people are still calling about specific patients. Occasionally, people are calling about general recommendations or enrollment. The very 65% are calling about a referral request, trying to find resources in their region for the women that they're seeing in their clinic. But almost half also have a component of a medication-related component. What do I do? What are next steps for medication? Is a medication appropriate here for a mom? And then 6% is for an emergency. And of course, as we say each time, we're not an emergency line, but we do want people to call us if they aren't sure what the next steps are, and we can kind of talk them through those evidence-based next steps and help them with any resources that might exist in their region. Next slide. So clinic engagement, when we're really looking at called once versus called multiple times here, we'd like to see this bar go up each month. February was the first month that it really stayed static, so we'll investigate that. That we want to see people calling us multiple times, finding this resource very important. We had, David, I don't know if you want to comment about the survey, but we had one of the highlights of the survey for me was that 100% of the obstetricians queried on that survey said they would recommend Peri-Pan. And so I think that's very exciting news. We need to continue our engagement, make sure they know that we're still here in these regions, and hopefully expand our engagement beyond. Next slide. So one of the exciting things about Peri-Pan is that we've launched a pilot-wide, actually statewide educational series. This is open not just to those in the pilot region, but also those across the state. And so we had our first webinar on February 21st, and our second is coming up tomorrow. And so anyone who is interested in this can register. We had 63 attendees in total, and we had several that were outside of the pilot region. We had attendees from UT San Antonio, UT RGV, UT Houston, UT Tyler, Texas A&M, UT San Antonio is listed twice, and UNT. And so we are really excited that we have gotten this message out that you don't have to be in the pilot region to attend one of these webinars. We are providing these statewide. And so we hope to see engagement in those go up and additional attendees. And then we are also working on developing the Project Echo with planned launch next month. Next slide. Right, this is just a list of the webinar schedule. If you want to screenshot this and let people know in your region, like I said, this is available statewide. So if the CPAN teams want to get this information out and let their pediatricians and family medicine docs and other primary care clinicians know that these are available, other obstetricians outside of those pilot regions. We would love as many people who would find this beneficial to attend our webinar series. And I think that's it. Next slide. Yep. All right. I am happy to answer any questions about PeriPan.
Very good. Any questions for Dr. Wakefield? All right. Sarah, I'm not seeing any hands right now. So again, thanks for the presentation and continued work. And with that, I think we will go on the Data Management and Governance Committee, an update from them. And Alex, I don't know if that's from you or who is providing that update. Is it Dr.
Sorry, I think that's
me.
Dr. Williams, or sorry, it says T-chat next on the screen. Are you still wanting to?
Oh, okay. Dr. Williams, is there more? Okay, yeah, let's do T-chat.
Sorry, I was just waiting for a pause and then
Okay.
let's go. I do want to also just remind everybody for CPAN, one of the things we're starting to do is we are starting to coordinate and collaborate with all of the 12 teams around the types of resources and materials that we provide in a consultation. There's a lot of great work that each of the 12 teams are doing, and we opted here to Dr. Wakefield's point that the providers really appreciate the information that we provide, but we also know that sometimes a provider in one area will get a different set of documents than another, and so we're working together across the 12 HRIs to sort of develop a template for provide resources. And this isn't a resources like a therapy referral. This is, a tip sheet on how to manage anxiety, a tip sheet on what to do if your child has had a trauma. So those kinds of activities. So we're going to work on developing some work groups around these areas and then collaborate with Luann and the communications team about where and how we can put them in on our website and other places, as well as just the utilization of them when we're taking consultations. As far as T-chat, next slide. The updates related to T-chat today are also pretty brief. We did, based on the recommendations from the evaluation team, start doing the Columbia assessment impairments, the Columbia impairment scale. So that's what that is. And that is a scale related to functionality. What we have made a decision about was that families, the parent, legal guardian would complete this form at the beginning of a T-chat episode of care. And then subsequently on every fourth visit, the parent or legal guardian would again be asked to be re-asked the questions again to see how the child's functioning has changed or not changed. This is a different type of instrument because it's looking specifically at functionality. It's not specific to a disorder, although we do remain committed to doing evidence and outcomes-based sort of care. And so we do have additional measures and tools that we're using, but we wanted to have this Columbia impairment scale utilized. And so most of the teams have had at least most of the young people have their parent legal guardian do the first one. This was started at the beginning of March. And so not too many families have had 4 sessions at that point. But as we start to have data related to that, we will start to share. The other thing that we did in the last month or two was, as the conversation was around case management, different teams had some different operations around how they help young people, and not in just a therapy session or a physician's appointment, but providing coordination of services during T-chat as well as once they're leaving the care. So case management is now something that we are accounting for in the trait system. And so we'll be able to see that separate from the session count of the therapy and medical encounters. Again, case management is always something that's done in collaboration and in concert with a family legal guardian as we move through care in T-chat, as well as when there's recommendations for care beyond T-chat. And then we are working through the process of being able to add into trait medications that are being provided with parent legal consent and guardian's approval. We have the first iteration of the frame of it, and now we're presenting this to the physicians across the state based on their feedback. Hopefully we'll be able to close the loop with that and be able to start collecting that data in the near future. Next slide. That's it for us. Any questions? Happy to provide any answers. Well, maybe, hopefully, I might know an answer. If not, Dr. Pliska.
Any questions for Laurel? Hearing none, Steve, let's go to you.
Sure. I have one slide to put up. I know whoever is governing the slides, or do you want me to put it up myself?
Lachelle's working on it and putting it up.
Okay, great. Okay. Could you go ahead and put that in the full screen view? Yeah. So I was going to try to make people aware of something and kind of get some general input. An issue that the data committee is struggling with is sort of where to go from here with the data. And we presented last month the kind of sort of immediate outcome data based on changes in PHQ-9 scores. And of course, that always brings up lots of other questions. Well, how about does this subgroup respond better than that subgroup? If you controlled for that, if you controlled for this, that, and the other thing, where can we go next? And I think it's important for everyone to be aware, we take a step back, that as we've said many times, TCHAT is 12 separate programs, each of which has its own procedures. And that brings up a kind of interesting issue in terms of the representativeness of the data when we move beyond very broad questions. So what this table shows is the number for a certain set period of time, number of people who have archived services. That means the individual has completed their treatment. And so everything we know about that patient is in, or what can be known about that patient in trait is in trait. And what trait is done here, the first column there's about 12,000 people who've had, completed the services. Now, what you'll see next column is that did a clinician or a person assign one of the assessments that is in trait? And you see that number varies tremendously across the different HRIs. Now, that does not mean that some HRIs are not doing assessments, but rather some are probably using their own assessments rather than the ones in trait. So if we look at that percentage, like I would suspect that for both Del Med and A&M, they've got their own internal system, probably within their EMR, that are doing more of that. Others are using trait extensively. So Texas Tech Lubbock, UNT Fort Worth are signing nearly 100% of those particular individuals. And then if we then break it down, then we looked at just the PHQ-9A and the Columbia, the numbers get even more variable because it might be that a particular site is not using the PHQ-9, is using a different depression instrument, or is not using the Columbia. And furthermore, each site is going to have different rules for how they implement that particular item. So for instance, some sites might say, well, we want to get a PHQ-9 and a Columbia on 100% of our clients, regardless of the chief complaint. Others might say, well, we're only going to get a Columbia on people who report depression as a chief complaint, or we're only going to do the Columbia on people who report suicidal ideation as a chief complaint. So what that would do at a very simple level is make it nearly impossible to compare data across sites, because a site that says only does the Columbia on people with a chief complaint of suicidal ideation might have 80% scoring positive on the Columbia. A site that does it on everybody might only have 10, 15% scoring positive. And it will be impossible for the data committee or for the trait statisticians to go in and really control for all of these extensive different levels of procedure in the different HRIs. So that leaves the data committee a bit on the horns of a dilemma going forward. one way would be, there's a number of different ways to go. One way is to say, we're not going to attempt any type of cross HRI data analysis, or we're going to be extremely cautious and limited because we know these methodological issues are there. And in which case we might only do within HRI analyses, and we would presumably oversee those and bless them for the methodological rigor of what a particular HRI is doing. So that's one view at that end. The other view is we begin to standardize across HRIs and standardize the use of trait. We've kind of, in its essence, done this with the Columbia impairment scale. But bear in mind, so far, that is the only instrument that we're doing that with. We're only saying, please use this instrument, use it at baseline, and use it at a specified number of follow-ups. When we get that, that's uniform enough that we can come back and say, in terms of the Columbia impairment scale, these are the demographics, these are the changes we're seeing, and that'll all be fine. But we couldn't then turn around and say, well, here's our data on the Columbia impairment. This is how it relates to depression ratings, ADHD ratings, suicidal ideation, because again, everybody is doing things differently. And the data committee is, we as a committee are not a policy-making committee in terms of how people do things at the level of the HRI. That's really a COSH and executive committee decision. So the reason I'm bringing this forward is for executive committee meetings to start to think about it. And I guess the data committee is going to need some degree of guidance from y'all in terms of what you want our mission to be going forward. And when we have those broader parameters, then it's easier for us to say, and it would involve not only the data committee, but the TChat leadership committee, because they need to have ownership of, yes, we want to say these things at the end of the day. What do we all need to do together to do it? And how can we do it in a way that's practical and doesn't unduly burden either families or the staff? So that's kind of the issue that I'm putting out there. And if y'all need time to think about it and want to put it on the agenda for a future meeting, that's fine. If people have, immediate information or immediate feedback you want to give the data committee, that's where we are right now.
Thanks, Steve, for bringing this up. If we could take down that slide and just so we can see everybody, I would love some feedback. Again, I appreciate, Steve, you bringing this up. I would say that from my position and talking to the legislature, et cetera, they like the data, and the more we can be consistent with how we display our data, the more transparent we are with them, and the support continues to build. It's a little bit hard to describe when we're measuring outcomes in different ways across a variety of institutions, and so. But would love to hear from others of what it would take, or if there's really important reasons of why we have these different measuring tools, or is there a possibility that we can move in a direction of having consistency in measuring these outcomes? Sarah, I see your hand.
Hi, yes. So we are one of the sites that has these instruments in our EMR, but I don't have any problem with switching over to trait so that it'd be accessible for this sort of purpose, and because all the clinicians are using trait as well, of course. So but also I think we'd get really good data if we just set it up in trait, that as soon as somebody is we would have to say when to send it, but we could make that something automatic. Of course, everyone would have to agree, but I would vote that it would take just one less thing for the providers, the therapists, to think about. And things that happen automatically, of course, always happen. And if they're not automatic, they sometimes happen.
All right. Dr. Wagner?
Steve, is a CGI being collected across all of the sites? You know, a clinical global impression of improvement?
It's not at this point. That would be I think, a very useful tool to do, because then we can compare improvements across diagnoses and severity levels and such. So I would certainly favor adding that as to one of the mandatory items.
Yeah, because it's so simple to takes, as you know, it takes about 1 second to complete, and it can be used across any diagnosis. So I think that would be great to add, because we'd have data for all of the sites and it's simple.
Very good. Dr. Wakefield?
Yes, I agree with both of what Dr. Martin and Dr. Wagner said. We did discuss the CGI when we were talking about the Columbia impairment as well. And so I don't know if Molly wants to weigh in on kind of why that decision was made. Because I think there were several of us that said CGI is so easy to do. And you know, so I think it would be worth spending some time maybe in a future meeting talking about the added helpfulness of having the CGI as well. But I wanted to comment on I don't know how many HRIs would be able to do this, but in reflecting on Dr. Martin's, how making things automatic, one of the things that we've been looking at for a while at Tech is the integration of trait with our EMR system. And I know we've discussed that in the past, but that way, because some of these things we do want in the EHR as well. And so wanted to just throw that out there, not that anybody can decide in this moment, but that it's one of the things that we've been investigating here about what steps would it take to have that integration. And I think that's something to think about because some of these scales we will always want in our EHR. And it would be nice to not duplicate that work if, for the foreseeable future. I know that's probably like a 5-year plan of integration, but wanted to get some, put that out there for discussion and reflection.
Thanks, Sarah. Any other comments?
I think what I'm looking for today, and I don't know if we need to take, David, if we need to actually take a vote on it or not, but does the executive committee want to give the data committee a mandate to pursue this? Not that we're not going to make any decisions right at this moment, whether we use the CGI or the revised children's manifest anxiety. I'm not asking for anything at that level, but I think the data committee does sort of need that instruction, and then similarly to the TCHAT leadership committee, so we can start to get together and have exactly these discussions that Karen and Sarah and Sarah have both brought up. And it will require a certain degree of flexibility with all the HRIs, because we all have our ingrained procedures that we tend to defend vigorously when these discussions come up. And that's before we get to the methodological issues of why someone prefers scale A over scale B. So this broader mandate issue is kind of what I'm looking at today.
So is there anyone here? I guess I didn't see Alex's hand. Alex, you go, and then I'll comment.
I was just going to piggyback on Dr. Wakefield's comment about integrating into the EMR. I believe Trait was in discussion with Delmed and UTRGV a while back to use a third-party vendor called Redox in order to integrate their version of Trait or their component of Trait with their EMR. I'm curious to where that is now, because if Dr. Williams, do you know the updates on that, or have that been dropped or anything?
No, it hasn't been dropped. So we actually have money in the budget to do integration for those teams that had wanted to pursue integration. The process is actually a two-way street, because it's more than just the securing of the funds. It's actually that institution, they have their own sort of processes that they need to do as well. So a couple of the HRs are kind of in that exploratory phase. And that's why, to Dr. Wakefield's point, it may take a couple of years, because it's not as simple as turning some, I mean, you know this already, Dr. Vo, but it's not as simple as turning it on. But My understanding is that there is, been preliminary talks. One of the teams needed to pause because they were going to move to a new EMR. Actually, I think 2 teams needed to pause because they were moving to new EMRs, and nobody wanted to think about integration while they were doing a transition to a new EMR. So there is still, that was part of one of the goals with funding.
Well, thanks.
Thanks.
So is there anyone that's opposed to looking at how we can standardize these outcome measures in a way that, again, that's consistent across our HRIs? Anybody that has a great reason of why we shouldn't go down that path? Okay. So I'm not seeing anyone. Go ahead.
Do we mean by outcome measures, are we also talking about the clinical measures? Because I think that was really what I was hearing Dr. Pliska say. I mean, I heard you talking about the CGI, but who's using the PHQA, all of those.
Right,
So when we say outcome, are we talking about our clinical measures as well?
Yeah, I think ultimately the mandate would be to select a reasonable group of measures, let's just call them measures for right now, that are relevant to the clinical status of the patients, both their degree of disorder and the response to treatment, that we want to get consistently so that we can have this large data set of over 15,000 clients and say something meaningful about them in terms of the impact we're having. If that's the mandate for the data committee and the TChat leadership committee, then we can start working together to work out all the, not insubstantial logistical issues that are there. I mean, there's picking the measures, there's making sure they get them done, trying to ensure that families fill them out. But we're getting the executive, I hear the executive committee saying to TChat operations and to data committee, please go down that road and identify the barriers and let's find a way to overcome them.
Yeah. So, Dr. Ibrahim.
Well, I do understand that we have different practices ingrained in different places. I would hope that the group and, several of these scales could be equally helpful and equally reliable and valid, certainly. But I would hope the group would be able to come up with one measure, standardized measures per domain, rather than just be stuck with what historically we have done in each of our centers, because that will allow us to really measure better what we're doing. So yeah, I'm fully in support personally of, empowering TChat and the data task forces to do this.
Very good. Dr. Martin?
And I was, I'm thinking about it from the patient view, because I'm also involved in the research project, and, those kids are getting paid extra to be involved in that. So we want to make something, and it's even hard to, when we're paying the kids to be in the research study, to get them to fill out all of the instruments. So we just have to be careful about what we make as mandatory. And we also might think about combining whatever core set we decide on, we want to put it all in one email link or one texting link.
I agree. And even the issue of, because just doing it by email creates a certain bias, because there are certain families that just don't respond to emails. So that's part of the reason that in some places the response rate is very low relative to others. So, but those are absolutely, we have to figure out a way to deal with those in order that our data we gather is representative of the population we're seeing. Now, study burden is absolutely going to be key variable that we'll have to look at. Or
Steve, I don't see anybody that's in opposition. So do you want to why don't we formalize this? You want to make a formal motion right now?
Yes.
Okay.
So I move that the TChat statewide leadership committee and the data management and governance committee be instructed to develop a method of getting a uniform set of measures, clinical measures, to assess the clinical status of the clients in TChat and their response to treatment.
Second.
Okay. I have a second. I have multiple seconds. Any further discussion? Hearing none, all in favor, signify. I see a hand by Ms. Wesley.
Yes, just wanted to make sure that again, we are looking at the opportunity for the interface and the electronic and automation, because I think that will help our caregivers not have to double document. And so I just didn't know if that needed to be part of the rationale for the motion, or just in general, that's kind of the guiding principle that we are going to include.
Yeah, Dr. I just wonder.
I think that's the, I
Stephen?
mean, that will come, I think that's an operational issue.
Charlie, you're on mute.
Oh, can you hear me now?
Yeah.
Yeah. So Stephen, I was just going to ask what your plans were in terms of what to do with the data once we get there. So let's say we have outcome data. There'll be a lot of data here related to regional differences, related to the number of visits in TChat. I mean, there are lots of variables. So you'll be creating a uniform database, which of course would want to be interrogated to try to determine all sorts of questions that all of us have. So I wondered, are you planning on fundamentally starting a subcommittee of the group that would involve biostatistical expertise, et cetera? Because, you know, now you're getting to the research side of being able to ask questions that we all would like to pose.
Yes, I think that's, we would say, here's the data set, and I think we would involve as many people at the various HRIs as want and need to be involved, and leverage the biostatistical expertise at the different institutions. And there would probably, yes, the data committee would probably need to establish a kind of subcommittee or publications committee that would kind of help walk through that issue. And I fully see somebody would say, I want to look at the TChat database to look at this question. We would say yes, and then give you the data set, and then your biostatisticians could work the numbers. You bring it back to the committee for review, and then it ultimately gets disseminated. So the data does not belong to the data committee; it belongs to the consortium as a whole.
That's great. Thank you.
Let's go to Lachelle, then Luann, and then Israel. Dr. Lebrazan.
Just a quick note, kind of going back to what we discussed earlier about getting a data person on the internal evaluation team. So part of the reasoning behind that was we want to have a central pool of data that has been vetted, is cleaned, that we can all rely on in terms of answering these types of questions. Are our programs effective? Are we connecting the population with services? Are we being equal across the state? And so I would see this new person that's being hired on the internal evaluation team would be responsible for pulling whatever data is from TRAIT. We know that TRAIT is a tool for capturing data. It cannot validate the quality of that data. And that's the piece that's been missing that we're hoping to plug with this new role. Now, that said, once we have a data set that is cleaned and is centrally managed, we can work with the data governance committee about what questions do we want to answer and who needs to be pulled in from a data governance perspective or from a statistical analysis perspective to answer questions, but making sure that we have that clean line of this data is being used to analyze the effectiveness of the services. We're not using it to conduct research on the kids that are utilizing the TChat services.
You were use it for quality improvement of the program. Luann?
I would be remiss if I didn't mention this, and I know we've talked about it at length at the data governance committee, but we really do not want to overburden families with instruments. And so we just have to think about that. How many instruments are currently being used per HRI, because I think there are many. And if we could have just maybe for the data governance and management committee, each HRI submit information about each one of the instruments that's currently being used, because I really am concerned about not overburdening parents and young people with so many instruments all at once, because then we certainly would have a low response rate. So I just wanted to reiterate that.
Dr. Liberzon?
So, I often say I wish I was smart as my mother-in-law after the fact. I don't want to be after the fact smart. I want to be ahead of so why I'm saying that, I think we're putting a little bit cart in front of the horse. Steve, in my mind, what is required for discussion, and it's important to start this discussion, is what type of question we would like to address. And that should define the type of data that is collected. And from that should define. So what we are talking about, something what Charlie mentioned, that what type of analytics, what type of biostatistical expertise should be done ahead of the time before we decide on the instrument. And the instrument have to be chosen based on that, because what kind of variables we'll need to do. It will be extremely painful if we collect all this data, and because we don't have particular variable included, all of that will be useful or confounded by the fact that we didn't collect something. So I absolutely agree with Luann, with everybody else, that it should not be burdensome, but it also should not be just data collection for data mining purpose. And because it often happens in the field, people collect data, and they do the secondary analysis and the tertiary analysis and then non-stop analysis, overanalyze this set of data, coming up with the same set of answers, which don't really advance the knowledge too much. So in my mind, what I would like to suggest that we start with what type of questions we would like to answer, what is the analytics that will be required to this question, including the confounding variables that we might need to, so the data will be meaningful, and from that move down to the question. That's my suggestion.
Well, yeah, I would agree that we'll probably look at what kind of broader questions that we're going to want to answer. Now, you want to bear in mind that there's a specific prohibition on doing research in TCHAT. So we really can't come out and say, well, we're going to develop a priori hypothesis and have this measure to do it and recruit people in. We've got to be very careful we don't step over that line. But yes, I think the discussions we've had so far have looked at the major symptom groups: depression, suicide, anxiety, disruptive behavior, the things that are bringing people to TCHAT. So I imagine our questions are going to be, what are the demographic and clinical correlates of those symptoms, and what are the mediators and moderators of outcome, as people move through the program. So those two broad questions will probably define the exact measures we're going to take.
Well, I think that should be actually discussed in more details. I agree with you, Steve, because the question is, since we are prohibited from doing direct research, we're not prohibited to studying the delivery process. We're prohibited for study. So, and I understand that, but then the question is, do we have enough data about the delivery process? Do we have enough data about, because when we say delivery process, the variables vary between the HRIs, vary between different geographic zones. Do we have enough data on that? Is that available? And so on. So to me, these questions are critical before we start collecting data.
Dr. Nemiroff?
Yeah, I agree with both Stephen and Israel and Luann in the sense that we, number one, do not want to burden the subjects. However, it's incumbent upon us to determine the efficacy of TCHAT itself, which is fundamentally what we're raising here. It's not so much a research question as a question related to, we've spent, a fair amount of resources providing a service to children in the schools, and we need to know what the factors are that influence relative success versus not. And so we can definitely do this, and I think it's going to be really helpful.
I think too, HRI should look at who they've named to the data committee and make sure that person is fluent in data and has the framework that can participate in answering these questions that Israel and Charlie have brought up. Sometimes on the data committee, it's that there are folks that are operational people, and their goal is, well, I want to make sure that nothing is interfering with the operation of TCHAT at my place. That's putting it a little too strongly, but if there are questions you specifically want addressed on the data committee, take a look at your voting member. If you think they're the person for you, great. If you think you need to make a change, each HRI has the right to do that. So that then each HRI's view on this matter, which is going to be very important, is taken into account.
All right. Dr. Ibrahim and then Dr. Trivedi.
I completely agree with Dr. Nemiroff. This is really about evaluating the impact of the program, and that will help us in the future actually get continuous support for it.
No,
Right.
no, I
Absolutely.
agree.
That's going to be probably our job one, is to look at what measures are going to be able to inform us about in a reliable way about the outcome. I think that's a no-brainer.
Dr. Trivedi.
I think in some ways we have to try to think about what we are talking about, because there is 3 levels of this. One is that just for the purposes of delivering better clinical care, what measures are essential. The second level is research, but we don't want to do that. And there is a middle level, which is what sounds like everybody's talking about, and that's assessing population level impact. And there, I don't think you need to change your clinical practice for the entire population to do that. I think what you have to then do is sample some version of it and get that answer that Charlie is looking for, because otherwise you're changing clinical practice to serve a different goal. So I think it may be worthwhile thinking about that as we are going forward. But
All right, very good. And again, I think everyone, I'm hearing the same message from different people. Again, this is to drive quality improvement in our program and figuring out whether this large investment from the state is making a difference. And the audience for that, and part of that is to the legislature, so we can tell them that we are good stewards of the dollars and it's making a difference. So I have a motion and I have a second. I'm going to call the question. All in favor of the motion that Dr. Pliska made related to evaluating ways to standardize this evaluation, signify by saying aye.
Aye.
Aye. Aye.
Aye.
Opposed, nay. Did anyone abstain? All right, hearing none, we have a unanimous approval. Dr. Pliska?
Very good. We have our marching orders.
Yep, very good. Thank you again, Steve, for all the hard work on this.
Oh, you're most welcome.
Deeply appreciated. With that, let's go to the update of the current legislative session. And Sean, I saw you on. Let me turn the podium over to you.
Okay, thanks, Dr. Lakey. Quick updates on some of the moving parts here we've got this session. I think we'd already spoken about the introduced budget bills in both the House and the Senate, including a very large portion of y'all's budget request, $280.5 million in each one of those. We did get that anticipated additional funding in the supplemental bill of $56.5 million. That is coming from the ARPA unexpended balances that we'll have left over coming this fall after the authorization ends. So put them together, y'all would be made whole at the $337 million budget request that you submitted last year. So looking really good on that front. Process-wise, the budget bill, it's a House bill this session, so they'll pass it first. It's up in their committee on Thursday in House Appropriations, and then another 2 weeks from Thursday, first week of April is when we're hearing they're going to take it up on the House floor. Once they pass it off the House, the Senate will pick it up, put in their version, pass it in their Senate floor, and by May, we'll probably have conference committee appointed with 5 members from each chamber, kind of hashing out the rest of the differences. But we don't anticipate there will be any differences in the consortium's funding. So it's in pretty good shape. You all have your marching orders in that respect. And so we'll keep monitoring it. Sometimes amendments take place on the floor, moving money from one place to another. And that we'll keep an eye on it and make sure that everything works out well at the end. The supplemental bill that includes the ARPA unexpended balance authority, that's up right now in House Appropriations. It's a Senate bill. So it's pretty far along the process. They'll kick that bill out, and then it'll be heard on the floor in the next couple of weeks as well. And that'll be kind of a done deal sent to the governor. So budget wise, funding wise, everything's looking pretty strong, and we'll continue to kind of track and monitor it. There's been some movement on legislation as well. SB 850 was heard last week. So this bill, as filed, would have added 20 members, a representative from each of the education service centers to the consortium's executive committee. We worked with the bill author on that. I don't think that was exactly their intent. So there was a committee substitute to make it just one member from a rural serving education service center would be appointed by you all to join you in the executive committee. That seems eminently workable and probably a good idea. They're getting involved, obviously. They hear from TEA, but it'd be nice to have a seat at the table. So we worked with them on that. They also, while they were at it, struck MD Anderson from the executive committee. As we all know, as the bill moved the process back in 2019, they were in there from the original version. And now as this kind of morphed into this child mental health care centric bill, there was less opportunity for them to be involved. So they'll be removed in that bill. And there's a couple other little tweaks that, once the drafters and the legislative council get a look at a bill, they like to add sort of stater language here and there. So they did add some language to the vacancy section of the bill about members to direct you all to create basically a policy on the length of the term and how to be reappointed. You guys already have that in your bylaws. And it explicitly specified that this new education service center member would be a 2-year term. They could be reappointed. They wanted to ensure some level of rotation ability should it come down to that. Again, I think y'all's rules already cover that, but they like to make the statutes pretty uniform as it relates to other different entities. So we'll have that in there. It did get voted out of the committee unanimously and recommended to be placed on the local and consent calendar in the Senate, which is sort of a fast track over to the House. So that bill's in decent shape. I don't think we have any issues with it. It's moving quite along. There's a few other bills that sort of tangentially hit upon y'all's operations. I think I mentioned last time I gave you an update, a few different bills that were clarifying that students can have excused absence for mental health treatment. Versions in the House and the Senate have gotten hearings in the committee, so they've made it a little ways along. There's also that bill I've mentioned before, and there's a version in the House and the Senate that would allow public schools to partner with LMHAs to provide mental health care for their students, and also authorize HHSC to add those schools as Medicaid providers to pull down federal funding. Both of those bills have also been heard in committees and received good attention. Haven't moved out yet, I don't think. So we'll keep tracking those. It may have, it's an optional thing. The schools may do it. It could be something that turns into, the next stage of, after you do your TChat sessions, maybe then you have a better shot to get quick and available treatment outside of that setting for follow-up. It could be that it supplements what you all do. We'll kind of follow that along in the process. HB 1898 is an interesting one. Again, doesn't completely directly impact the consortium, but it would provide grant funding to children's hospitals. This is a big priority of the Children's Hospital Association, for them to develop, and the grants are okay for planning, for development, for capital improvements, and for transitional operational support to create more services and programs for child mental health care services. Again, sort of like another supplemental program where the state would be putting more funding towards increasing the availability of these services. That bill's being heard this afternoon, so we'll monitor that and see how that discussion goes. And then just generally, there's, I have a list of 30 some odd bills that in some way, shape, or form could impact the consortium's activities, usually indirectly. And as those come up, we are engaged with the authors to make sure they understand how you all are implementing the directives you've gotten from the legislature, and just ensuring sort of continuity in operations as those pieces of legislation move about. That's my quick update. I'm happy to answer any questions about anything I brought up or anything else you've heard about or is on your radar.
Thanks, Sean. I appreciate that. Again, on the budget, we're very pleased with where we are right now. We put in several things that you requested us to put in: the statewide rollout of Peripan, the broadening of YAM, the other ARPA funds programs, and making them continue past the length of the ARPA funding. Again, the statewide rollout of TChat, so every school in Texas will have that available. And so and the variety of workforce issues and programs that you had sent us, and thus far those are funded. So we're very pleased on those and the steps forward on those initiatives. Again, as Sean noted, there's a large number of bills that in one way or another could impact our work and how we implement our projects, and we continue to watch those. And where it looks like there may be a misunderstanding or an opportunity to influence those bills in a positive way, Sean and the team have been working with the legislators to make sure that they understand the intended consequences and unintended consequences of bills that might move forward. So with that, are there any questions or comments? I'm not seeing any hands.
Take that as a sign of an excellent presentation.
Absolutely. Actually, a question, Danette Castle. I know you guys have been working hard on your area of the funding that impacts the work that we do. Any updates from your team?
I think simply that I would say that at this point, the House Appropriations Committee has in fact adopted into the state budget for this point in the process the workforce recommendation that we had for appropriation. So we were really pleased. That's 127.3 million that would allow us to really address the workforce challenges that we have playing themselves out right now. So that's probably the highlight. We have a number of other bills we're tracking and working on, but of course we're paying close attention to appropriations.
Very good. No, that's good to hear. That's what I wanted to hear. And so again, our work isn't going to be successful unless the local mental health authorities are successful and able to meet their needs. And again, appreciate the strong partnership between us and your work. So congratulations, and we'll continue to watch that.
You know, that did actually remind me of one more bill I didn't mention specifically that you guys might want on your radar. And it's a priority bill on the House side, creating some grant programs for higher education to increase the number of mental health professionals at all levels. There's a psychiatry aspect of that bucket, and there's another bucket for all sorts of the whole level of counselors on up, and psychologists. So the theme here is that the legislature is continuing and really bolstering and increasing its several session now commitment to improving mental health care, workforce resources and services in the state.
And Sean, correct me if I'm wrong, but I think in that bill or in another bill, the funding for the forensic psychiatry training to expand the availability of fellowship slots in Texas for forensic psychiatry.
Yeah, absolutely. And along with some of the state hospital construction and putting aside beds in that for forensic, it's another important aspect of this. Yes.
Okay, very good. Any other questions or comments? Dr. Nemiroff, you want to say something about the?
I'm just wondering whether you want to comment on the brain bill, which is coming out of the House, and we know about the past history, but my understanding is that Representative Craddock has signed on as a co-sponsor, and I just wondered what your thoughts were about it moving forward.
I think, it still has a bit of an uphill climb. It's just a big price tag, big initiative. It takes a lot of pushing in the same direction to get something like that over the line. It's actually I've got several screens up right now. It's going to be heard in higher ed momentarily, and we'll hear how that conversation goes. I think, frankly, the biggest hurdle it had was the previous versions relied on bonding to fund it as like in CPRIT. And that was not a favorite approach in the Senate. So this version instead, it just takes some of the surplus that the state has on its hands right now and puts that 3 billion towards it. And there's a constitutional amendment, so that's not, because it's dedicated to the Constitution, it wouldn't count against the spending cap. So I think that increases its chances to an important degree. Really gets rid of one of the major obstacles that it had in the past.
Thank you.
Very good. Any other questions, comments? Hearing none, I think we're at the end of our agenda. Are there any other comments, things that are germane to the agenda that we need to bring up before we close this meeting today?
Not for me.
All right. Well, I don't hear any. Again, a big thank you for all the work that you're doing to continue to roll out these programs. We will continue to work with the legislature to make sure that the funds that we are counting on get put in place and that we identify any issues in other bills. If you see any issues in other bills, I know several of you have sent me items to take a look at. Please continue to do that. Again, we want to make sure that if there are consequences, intentional or non-intentional, that will impact the delivery of our services, that we make sure that the officials fully understand those implications. So again, thank you. I hope you have a great week. Talk to you soon. Thanks.
Thank you.
Thank you.
Thank you all.